Welcome back. This is Module 2 for the C3IFT course, and this particular section is going to look at protocols and operations. So we're going to look at the skills, procedures, and the medication interventions that are out there, understand the classification of drugs in the procedure list, review the 3000 series protocols, and talk about the modes of operation discussed within the context of C3 and plan for an introduction of the C3 course. So just as we had mentioned in the previous lecture presentation, we talked about Class 3 being the C3 Interfacility Certified Paramedic. And we talked about how the drugs were classified based on whether you were administering, re-administering, or if you're monitor the infusion only. So those are listed as 3, and it's either A, B, or C. And then we also have a similar presentation for the procedure classifications. Let's look at those. So the procedure classifications won't have a B, but they will either have an A, meaning you're performing the skill or you're monitoring what has already taken place. Again, we're looking at a Class 3A or a Class 3C skill. Now we're going to look at some of the specifics out of the protocols. And our primary protocol, the big thing that you want to remember is that when you're transporting these patients, they must be stable. We mentioned that in the previous presentation. They have to be considered a stable patient by criteria, otherwise it turns into a CCT call. The question of stability in a pediatric patient is ultimately determined by the medical command physician. Class 6, Class 5, and Class 4 also use part of this protocol, and all Class 3 drugs are provided by the sending facility, and the sending physician must provide written orders for type and dose of medications to be utilized in the transport. So no drugs or procedures that are above a Class 3 may be transported by you as a C3 medic. You want to document all medications and amounts received from the sending facility, and all patients have to have an accepting physician's name prior to leaving the sending facility. All unused medications must be turned over to the receiving nurse, who has to sign your patient care report attesting to the amounts that they've received or wasted in the excess of the medication as appropriate. In the event that unforeseen or unanticipated events develop during the transport of a C3 patient, you want to make sure that you do utilize the 4000 series protocols. You know, you're taking a step back and looking at emergency care at the 4000 series level. Contact medical command and let them know what's going on. So our first protocol that's specific for C3 is called the 3101, and it talks about volume expanders. And as all components must be infusing prior to initiating the transport. And only the unit of blood that's hanging may actually be continued. Additional units cannot be hung or started by the C3 medic. That's considered a CCT skill. So you can only let them finish out whatever blood has been initiated prior to leaving the facility. And your colloids, those may be re-administered and titrated by the C3, but you want to make sure that your infusion rate is set by the sending physician. If you are in a situation where you have to re-administer or titrate those colloids, you really need to have that conversation with the MCP. Blood and blood products, going back to those, they have to be infusing for at least 15 minutes before leaving that sending facility. And the reason being is we want to make sure that there's not going to be any allergic reaction or reaction to the blood that's hanging prior to you leaving. So it takes about 15 minutes for that reaction to develop, and so you want to allow the time for that blood to be initiated, run about 15 minutes, and then leave with that patient. And if you're being really cognizant of your activities while you're there, you can actually do other things like your patient assessment, gathering the documentation, making sure that you have all of the orders from the sending physician. All of that can take place while that blood is running. So that kind of helps eat up a little bit of that time. In the 3202, protocol, this talks about hypertension and using the nitroglycerin to control that. As a C3 medic, you can titrate and monitor the drip, but the state does not allow you to initiate the infusion. So the rate and the titration is going to be set by the sending physician. Nitroglycerin is the only drug that's utilized as a part of this protocol, and it's usually titrated in 5 microgram per minute increments. And remember that this nitroglycerin is not based on the patient's weight. But you may titrate or monitor at the rate set by the sending physician. Make sure you remember that. That's why you have to have those orders in place as you go. The systolic blood pressure parameters need to be set by the sending physician as well. They're going to let you know. A lot of times the physicians will tell you, it's okay for it to be less than 90 as long as it's not below 60, for example. But you want to make sure that the sending physician is the one that sets those parameters for the blood pressure for you. That way you can titrate and maintain based on that amount. And remember, we're doing it in 5 mic per minute increments. And again, nitro is the only drug that's being utilized in the hypertension protocol for 3202. When it comes to our antiarrhythmics, there are 3 that are seen in the C3 realm. That includes amiodarone, diltiazem or cardizem, if you will, and procainamide. And these medications are a monitor-only case for the C3 medic. The rate is again set by the sending physician, but you at least are able to monitor these medications as they are infusing during the transport. In 3204, we're looking at our vasopressors, and there's only 2 vasopressors that are utilized and recognized for C3 medics, and that's including dopamine and dobutamine. But the big thing to remember with the C3 medic is that you can only monitor or titrate 1 vasopressor. If it's more than 1, if they have more than 1 vasopressor hanging, then it becomes a CCT call, automatically becomes a CCT call. And the infusion rate, as with everything we've seen up to this point, it's still set by the sending physician. And remember, only 1. You can only take 1. Anything more than 1 means that it goes up a level and it goes to the CCT realm. 3301 is the bronchodilator protocol, and in this case they include the medications Alupent and also the theophylline infusion. So the rate is set by the sending physician. The theophylline is a monitor only, and we're going to look at those medications a little bit closer in the next module. Antivenom, it's not used regularly, it's very rarely seen, but in the situation where you have a sending facility that's initiated the antivenom, so we're looking at someone who's been bit by a snake and we are wanting to continue the infusion of antivenom during the transport. The biggest concern we have with patients that are on antivenom is the chance that they could have an allergic reaction, because typically the antivenom is derived from horse serum. This case, it's a monitor-only infusion for the C3 medic. You're not going to be initiating or restarting anything with the antivenom. You're just monitoring it. 3602 is antibiotics. Here's another thing as well. Just like with blood, the blood has to run 15 minutes. The same thing happens with the antibiotics. It has to be running 15 minutes before you leave the facility. So we want to make sure that they're not going to have that allergic reaction. Also, just as we saw with the dopamine or the dobutamine, those vasopressors, they can only have 1 antibiotic hanging. So just like with the vasopressors, if there's more than 1, it is no longer considered a C3 call. So if you show up and they have more than 1 antibiotic, you have to call for another unit. 3603 talks about anticoagulants and antiplatelets. There are 4 medications that are approved. This includes heparin, aggrastat, Riopro, and integralin. And the 3604, this is our nutrition protocol. This includes the potassium chloride, mag sulfate, and also the TPN, or the total parental nutrition. But let me take a minute to look at the potassium chloride. Anytime you're transporting potassium chloride, it has to be on a pump, and the concentration cannot exceed 40 milliequivalents per 1,000 milliliters, and it must be given over no less than 2 hours. So if you run into a patient that has potassium chloride hanging, remember those three things. It has to be on a pump, it cannot exceed 40 milliequivalents per 1,000 mLs, and it can't be given in less than 2 hours. It has to be greater than 2 hours infused. With 3605, we're talking about the nausea and vomiting protocol. There are 3 medications. You have phenergan, Zofran, and then the compazine. And it's ordered by the sending physician. The biggest thing that we look at with this is that our primary one that we want to go with is the Zofran. It has less side effects than the phenergan does, or the compazine. 3606 is the neurological emergency protocol, and it is a monitor only for the C3 medic, and we're talking about medications such as mannitol and solumedrol. These are the only 2 that we're looking at. Again, the rate is set by the sending physician, but it's a monitor only. Some patients, particularly the ones that are intubated, are also placed on a proton pump inhibitor, a PPI, and we're talking about Nexium, Prevacid, or Protonics, and those are ordered by the sending physician. They can be re-administered, titrated, or monitored by the C3 medic, so you have a little bit of flexibility with these 3 drugs. 3901 is our analgesic protocol, and we're looking at either morphine, Demerol, or fentanyl. The dose is going to be ordered by the sending physician, and the big thing to understand here is that while you do have these 3 analgesics to choose from, only the morphine sulfate is approved as a continuous IV infusion. So remember, this is an IV infusion that we're monitoring, and again, that's only morphine sulfate. You cannot do that with Demerol or fentanyl. That becomes a CCT call. The 3902 talks about sedation, and the big thing that you want to understand as a C3 medic is that you are administering these as an IV push only. They are not a continuous infusion for this level. The doctor is going to order those, give you the dosage that's being ordered, and the 3 medications that we are allowed is the Versed, Ativan, and also the Valium. Now, we do have to remember that anytime where you have a patient that can be over-medicated, we want to try to have the reversal agent present as well. So in 3903, we're talking about the reversal agent protocols, and the medications that we are provided for this includes Narcan for our opiates, flumazenil or romazicon, and the calcium gluconate. And again, the medication and the doses are provided by the sending physician, and the administration of a reversal agent is only by MCP order. So that's really important for you to remember when you're transporting these patients. If you think you need to give that reversal agent, you need to have that conversation with the MCP. Now, each of those reversal agents works for a different item. So the one we're most familiar with is the Narcan, and it does work for the opiate overdoses. But the 2 that we're less familiar with, or we see less commonly, include the flumazenil, which the other name for that is romazicon, and that is used specifically in the case of a benzodiazepine overdose. We're looking at someone who's overdosed on Valium or Ativan, for example. And then the calcium gluconate is actually the reversal agent should we have a patient who has suffered magnesium sulfate toxicity. And mag sulfate is given to patients that are in premature labor or they are experiencing preeclampsia. And so it may be that you have that mag sulfate on board, and it is an infusion, and you're monitoring that infusion, and you see toxicity. And remember, toxicity, or the magnesium toxicity, will present to you with a decrease in their mental status and also the potential for respiratory depression. So if you see either respiratory depression or the decrease in the mental status, you want to consider it to be magnesium toxicity and utilize the calcium gluconate as your reversal agent. And then finally, we have the 3904 protocol, and this is for paralytics. And the patient must be intubated and medically stabilized by the sending physician before you leave. Must have had at least one dose of the medication prior to transport, and the C3 medic can actually re-administer by IV push. But if you have a patient who is paralyzed and intubated, you need to have at least an EMT or higher in the back of that ambulance in order to help assist with the airway management. But the only medication in this case is going to be Norcuron. And this actually concludes the section on Module 2 for protocols and assessments, and we are going to look a little bit further into Module 3 and talk about the pharmacology of some of these meds.